I talked to one of your previous graduates, who's one of our fellows now, Kat, and I also talked to Peter about what do you think would be good to discuss. And I had a whole bunch of topics, and both of them independently said trimodal therapy. So I think there's a hidden agenda here. Maybe it's directed at Martin, but these are my disclosures after yesterday's session with the residents. Now you know what this means. So when people flash up this slide, you know what this means. We talked about that yesterday. Okay, we're going to have three main points today that I'll go over. Understanding the literature and the background for trimodal therapy. Then number two are the practical aspects, how we do it at the University of Toronto, and some ongoing controversies updates where we need additional data and work. So radical cystectomy, we know, is the gold standard for localized muscle-invasive bladder cancer. The radiation oncologists like to call it a standard of care, but I think realistically we know as surgeons that this is the gold standard, has the track record of decades of success. We know we can cure people with the operation. It gives us pathology, nodal sampling, nodal clearance, excellent local control, durable survival, huge series that suggests that we're doing good with radical cystectomy. The problem with our gold standard, though, is it is underutilized. So the very first line there is a SEER study that John Gore did way back now in 2010, JNCI. And you can see on the far right, of people with localized muscle-invasive bladder cancer, 51% in SEER received surveillance. So nothing. That doesn't work for muscle-invasive bladder cancer. Radical cystectomy, only 21%, 28% got some form of radiation. So we're completely undertreating these individuals. The next study, a few years later, National Cancer Database, very similar findings. So the hashed blue bar are the surveillance or observation patients. So one could maybe justify that theoretically in a 90-year-old. Although we do have radiation, we can at least treat them with some form of definitive therapy. But look at how many patients, less than 50, 51 to 60, 61 to 70, 20% are not getting treated based on these database studies. We don't have these data in Canada, but it is something I think we can look at in Ontario with our databases. So I'm going to try to look at that. Yeah. So in SEER, I think it would be indirect validation. So if those patients die quickly, then most likely that would be an indirect, like a calibration type of exercise. But I don't think you can actually get the individual patient data. So what I'm going to have a fellow coming from Switzerland starting in August, and that's what I wanted to do in our data set. So we have gone through 120,000 TURBT reports in Ontario. So he can look at anyone who had T2 and above, and then link it to our database to see who actually got surgery. And our codes for surgery are actually quite robust, like 98, 99%, because if you have a code for cystectomy, the chances are it's not a miscode. So we'll be able to define that in Ontario. In Canada, we don't have that. I know Peter and I have talked about it, but I suspect it's happening, but we just don't know. So why is cystectomy underutilized? Morbidity and mortality from it. It's a big operation. This is the Memorial Sloan Kettering data, over 1,100 patients. 64% of their patients had a complication, 83% were Clavian 2 to 5, and they had a readmission rate of about 1 in 4. And we looked at our NISQIP data at the University of Toronto, and we're the same. We have about a quarter being readmitted in the 30 days after their operation. The mortality rate is anywhere from 1 to 6% overall, depending on the series, and in octogenarians, 7 to 13%. So it's a big operation. Patients have a longer post-operative course, and they go through a lot. Their quality of life is hit with the operation for about a year. That's what our quality of life data show in terms of physical and role functioning. There are long-term implications to sexual, bowel, and urinary function. And the one thing I tell my patients, this is a study on the bottom right from Kareem Kader, looking at weight loss after cystectomy. So at 2 months is when we hit our nadir. So I'll usually tell my patients, you're going to expect to lose at least 10% of your weight. So that's a bit of a shock to them, and it helps them when they come for immediate follow-up for path review, and they say they've lost weight, and I say, well, that's expected. I told you it would happen. So patients need to go through short-term pain for a long-term gain, right? I'm not saying that cystectomy is the wrong thing to do. It's just they have to go through a lot. So maybe we can entertain another treatment modality that can potentially provide the same kind of oncologic outcome while decreasing some of the morbidity for patients. So that's where trimodal therapy comes in. Trimodal therapy is a maximal TURBT with chemotherapy and radiation, so 3 modes of therapy. There's 2 distinct groups. Most of us wouldn't argue that those unfit for surgery, we should treat them with radiation as opposed to observing them or surveying them. That's not really controversial. This is the more controversial group, the patients coming for bladder preservation. Can we not compromise oncologic outcomes by maintaining quality of life? So in Toronto, these are our criteria. So 5 centimeters. Some of my colleagues will do 7 centimeters, but most of our publications will say 5. Unifocal, no hydronephrosis, minimal to no CIS because it's known to be radio resistant. Okay. Good bladder capacity and function, and they need to be compliant with follow-up. Those are the ideal patients. And there's 2 different ways we can administer trimodal. The Mass General group on the far right-hand side does split course. So they do their induction radiotherapy 40 gray with concurrent chemo. Then they do biopsies, assess for response during treatment. And if there's a complete response, finish off. If there's not, go to cystectomy. We in Toronto and also McGill and most other jurisdictions just do continuous full course. So patients will get all of the radiation with concurrent chemo. And pre-pandemic, we used to do 40 gray to the bladder and pelvis and 24 to 26 gray boost to the tumor with platinum at 40 milligrams per meter squared. And then we assess them afterwards. And how you assess them, I have a few slides on that after, because that's also controversial, I would say. Since the pandemic, we've hypofractionated, so 55 gray and 20 fractions, based on a couple of randomized trials that have come out in the radiation oncology literature. Here's one of them. So this is BC 2001. And this was the study that suggested we should be giving chemotherapy concurrently as a radiosensitizer with radiation therapy. So they randomized patients to radiotherapy alone or chemo rads. And the chemo they use is 5-FU mitomycin. You can use platinum, which is what we use, or gemcitabine. There's no difference in the type of radiosensitizer that we know of thus far. Gemcitabine is probably a bit easier to handle for patients, but the platinum is only at 40 milligrams per meter squared. So it's half the dose that they would get for neoadjuvant or adjuvant or palliative chemotherapy. So it's actually well tolerated, and it's once a week during the radiation. So this study showed improvements in local regional control. They've never actually shown a survival benefit in terms of cancer-specific survival or overall survival with combined treatment, but the Kaplan-Meier curves have looked quite promising. Their p-values are 0.1, 0.08. So we've more or less accepted this as the way to treat patients. It's not bimodal therapy, it's trimodal. Okay, so MGH outcomes, probably the longest follow-up and the biggest data set. This is an older study, and 348 patients up to 2002. Back then, they had a salvage cystectomy rate of 29% and an overall survival at 5 years of 52% and disease-specific survival of 64%. And I think as urologists, if we looked at that, we would say, well, we can do better than that with surgery. So what they did was they updated their data later on, and the red line is actually their updated data set. So you can see that there's much better, vast improvements in terms of overall survival and disease-specific survival. 80 to 85% is what I think we could achieve as well with cystectomy in a T2 setting. So whatever they did, they managed to at least get up to that level. And what they did was they selected their patients. So here's the table 1 from their study. And you can see on the left-hand side, back in the day, 86 to 1995, only 40% of their patients were clinical T2. So T3s and T4s were 60% of their patients. And then on the far right in the circle, you can see no one got treated beyond clinical stage T2. So they really pared down who they're offering this to. And then at the bottom, hydronephrosis, they use that as an exclusion criteria as we do. So basically cherry picking or picking the right patients, but I don't think there's anything wrong with cherry picking if we can get the same outcomes. Overall, we think that 20 to 25% of patients are eligible for trimodal at the most. So we would never recommend it for everyone. So I think if someone says that, then you have to take that with a grain of salt. What about a randomized trial? So I've been asked about this before, and the Brits are the best at doing this, and they failed trying to do this. So they tried to run this trial called SPARE. It was a UK-based feasibility trial. It was a non-inferiority trial. So what they wanted to do is prove that they could actually accrue and randomize to cystectomy versus trimodal therapy or chemorads. I don't know if they're going to do a maximal TUR. And to show non-inferiority to cystectomy, they needed 1,015 patients. So they said, well, let's do a pilot to see if we can actually do that. And they said, we need to actually randomize 110 in 2 years. Then they changed it to 3 years because that even 2 years was too much. And in 3 years, they only managed to randomize 45, so they closed early. And there was a lot of non-compliance with treatment crossover. So I just don't think a randomized trial is feasible now. And if you were to do it, then you would have to frame it as a superiority trial, which is not, I think, what we're trying to do here. I don't think anyone's going to say that trimodal therapy is superior based on the data we have now. I guess you could posit that cystectomy is superior. That would be one way. So I think the best way to do these types of analyses right now are single institution matched studies. So we did that propensity matching with our cystectomy database and our trimodal therapy database. So this is back in 2017. So the data set was up to 2015, 2016. And we had 56 patients matched with trimodal therapy to radical cystectomy, matched on age, ECOG status, Charlson comorbidity score, clinical stage, CIS hydronephrosis, date of treatment. So we had a lot of granular details in terms of our matching. This is table one. After matching, everything looks very nice, which one should expect after a propensity score analysis. So pretty equal proportions for all the variables. We had 20 deaths in the cystectomy arm or group, 22 in the trimodal therapy group, and 13 deaths from bladder cancer overall in both of the groups. These were our Kaplan-Meier overall survival and cumulative incidence functions. So not much of a difference, and the p-values are far from significant. Our 5-year disease-specific survival was 73% for cystectomy and 77% for trimodal therapy. And held up in multivariate analysis as well. And our salvage cystectomy rate is around 11% in Toronto. So those are now getting older, those data. So Alex Zalata presented this at GU-ASCO last year, and it's been submitted. These are updated data. So what he did was he took our data set of patients, of cystectomy patients, along with trimodal therapy patients, brought in the Massachusetts General trimodal therapy patients and the USC with Dr. Dineshman's cystectomy database and combined everything. So it's basically just a larger duplication of what we did locally. And so ultimately we had 722 patients that we could match. 440 had cystectomy, 282 trimodal therapy, and the primary outcome was METS-free survival. And on the left is the propensity score matched Kaplan-Meier analysis. On the right, inverse probability of treatment weighting, which is basically just another way of doing propensity scores. So the Kaplan-Meier curves here you can see are completely overlapping. Suggests that we can achieve similar outcomes with trimodal therapy in our specially selected patients. What I haven't shown is the overall survival, and there is a hint of or clear separation demonstrating that trimodal therapy has better overall survival. So I think there is an element of selection here for sure, and that's what we went back and forth on as co-authors, and have gotten feedback from reviewers on that. But until we can actually do a randomized trial, which is not going to happen, at least I don't think, this is all we have. Yeah. Yeah. So these ones are matched on age, ECOG, clinical stage. So tri-modal therapy is guideline endorsed now within AUA, EAU, CUA guidelines, NCCN as an option as well. So it is slowly making its way into the out of Toronto and out of Boston, out of McGill, which I think are the biggest centers in North America doing tri-modal therapy. Okay, so the next part of the talk is going to be the practical aspects. Any questions before I go into that, or any others?
I noticed that the Mass General group had 20% of them had CIS, and I thought that was an exclusion criterion.
Yeah, ours also have CIS, about 15 to 20% as well. But I guess what we say is there's CIS and then there's CIS. So if it's just a little bit around the tumor, maybe we could resect it, visible CIS, whatever we can see with a maximal TURBT will allow it. But if the whole bladder looks velvety red or they have a lot of symptoms suggestive of diffuse CIS, we would never want to put them on. Same with hydro, like we'll allow a little bit, but.
What I meant about asking about age was also, is there a similar inclination to recommend trimodal therapy in a person in their with long life expectancy versus a shorter life expectancy? And is that reflected? Your age matched there, but are they age matched and older than, say, a cystectomy population where you're perhaps more worried about long-term follow-up and recurrence over time?
Yeah, so they're all age matched, and the other concern is secondary malignancy. So if it's a 50-year-old, we do talk to them about that. The radiation oncologists, I don't know if there are any here, but they don't seem to want to talk about it, but I make sure that the patients know. I'll talk about how we approach patients, but we're basically there together. But I think if you have someone with a life expectancy of 10 years or more, you have to talk to them about secondary malignancies. But in that study, yeah, they were all age matched. So if we had a 50-year-old trimodal therapy patient, they would get matched. I think it was 5 to 1 or 3 to 1 to a 50-year-old cystectomy patient. Okay, so now some practical aspects should we want to implement this outside of Toronto. So the way we do our trimodal therapy is through this clinic, our multidisciplinary bladder cancer clinic. This was established in 2008 when I was a resident, actually. I was just finishing my thesis and came back, and then I showed up at UHN and we had this clinic. And it's run in cystoscopy on Wednesday afternoons. It's initially meant for difficult bladder cancer cases. So anyone in the community or other urologists can refer non-muscle invasive, muscle invasive, or metastatic patients in. For the most part, everyone in the Greater Toronto area and in our hospital knows it's a trimodal therapy clinic because we have a radiation oncologist there. So they know that that's the real purpose of the clinic. And we have socialized this with the community around us. So on an annual basis, we'll have a multidisciplinary bladder cancer clinic evening where we'll get an invited professor to come. So last time we were able to do it, we had Ashish Kamat come, we've had Bernie Bachner come, as a means of getting the community urologists out and just advertising that this clinic exists. And that's been pretty successful. So everyone knows that if someone wants trimodal therapy, they can send them to this clinic, or if they don't want to deal with a patient because they're 90 and they don't, with a ton of comorbidities, what do I do with the patient? I'll just send them in. So yeah, the goal is second opinion for complex bladder cancer cases. And it does allow us to offer multiple treatment modalities to patients that they may not get elsewhere, including clinical trials. And it allows us to have an interdisciplinary discussion of care. So the way we do this is the radiation oncologist comes over and we actually see patients together, assuming they're MIBC. They'll leave if there's a non-muscle invasive patient, and they're not involved with those. And when we scope patients in follow-up or initial assessment, the radiation oncologist is there. They don't actually do any of the scoping, but it's nice for them to see what we see. And they've become quite good in our clinic at recognizing what telangiectasia are and what a recurrence is and what a large tumor is like and what multifocal means, and even understanding the cystoscopic translation to an axial image, because that was something that I think took some learning for them as well. We have a coordinator dedicated for the clinic who puts together everything for us, so it makes it easy for us for these complicated patients. And it's almost like having a bedside tumor board because we have at least two of our disciplines there. At one point, we had medical oncology fellows as well. So there would be three of us. If we do want medical oncology opinion, Kala Sridhar is running her clinic across the street. So we can almost ring her up or send someone there. We try to make it as multidisciplinary as possible. And it's advantageous because patients, it's very patient friendly. They have simultaneous assessments by bladder cancer experts. I think seeing the patients together decreases bias. So you can't have the radiation doctor go in and say, no, you'll be fine. Radiation's great. And you can't have the surgeon go in and trash radiation therapy. So we're held in check, assuming the personalities allow that. I guess nothing stops you from trashing the other specialty. And it allows two sets of eyes at the minimum to look at investigations and imaging. So the surgeons and radiation oncologists are quite good at looking at imaging because of treatment planning for dosing or for surgery. So to have two of us along with the radiological interpretation is quite good. So this is what our coordinator would do. So we walk into clinic and we'll see 8 to 10 patients in an afternoon. So it's not a very heavy clinic, and the coordinator puts all this together. This is easy for us, and I'm sure there's a way to even make it easier with color coding, et cetera. But when I look at this, I can just say, look midway down the page and say, oh, okay, they had neoadjuvant at this point. And then further down, just because of the way it's written, it's very easy for us to identify when they had their tri-modal therapy. And they basically just keep this as a Word doc for every patient. And every time they come in, they update it and provide it to us in a compiled Word doc. So it's very easy to for follow-up, and make sure you don't miss anything. The way we give our radiation in Toronto is usually with neoadjuvant chemo. So we're proponents of neoadjuvant chemotherapy, and I'll talk a little bit about that later on. We use a fiducial marker called Kulkarni, and where necessary, debulk. So we just don't want visible tumor. And like I said, in the past, we used to use 64 to 66 gray in 23 fractions, and now we're down to, in 33 fractions, and now we're down to 55 in 20 fractions. And that was based on what the radiation dosing they used in BC 2001, that study I showed early on about chemosensitizing. And there was an older study called Beacon where they used carbogen and nicotinamide. So carbogen is an inhaled agent, and nicotinamide is an oral agent, and they would take it just before radiotherapy to help with the hypoxic environment. And it showed improved overall survival. We don't do that, although our radiation oncologists want to bring it in, so they'll probably eventually do that. So that study used 55 and 20, so that's why we moved to that. So a little bit on Kulkarni. So it is a radio-opaque contrast agent, and it comes in a 10 cc tube, and it's a thiodized oil made from poppy seeds. And you don't have to give a lot of it. So this is what it looks like. And it's usually used for lymphangiography, but which we rarely do anymore. And it comes in this 10 cc vial. We only need 1 cc at the most. So there is wastage. It costs about $300. So if we have 3 patients coming in, then we can at least split it. But that's really rare. I would say in Toronto, we treat 1 to 2 patients a month. So it's, like I said, it's not for everyone, and we're very careful on who we select. This is how we instill it. So in the past, we used to use a rigid scope under local. That's old school. I think I was one of the last ones in our institution to learn on rigid scopes. Ben taught me when we were residents together. But it was really uncomfortable for patients. It was torture, and I hated doing it. And then Peter wanted to open a trial called Rito, which never really did open. But when he sent me the protocol, I was reading it, and I thought, oh, we have these flexible needles. So I just, from reading the protocol, I phoned up our Olympus rep and said, I need these needles. So now we just use these needles that go through the flexible cystoscope. It's so easily tolerated by patients. And you can see the little in the top right, and the top left is actual needle. It almost looks like a basket. But on the top right, you can see how much of the needle protrudes, and that's a little bleb of Kulkarni that's coming out. It looks like fat. And then we just stick it into the scar, the periphery of the scar, or if there's actually a tumor resection bed, we stick it around that. And this is a cartoon of what it would look like. So there's your resection site. And you can see we're trying to delineate the outside of the tumor. And there's no rule of how we do it. We basically will go circumferentially around. Maybe we'll do 4, maybe we'll do 8. It just depends on how easy it is to get in and how large the site is. Patients tolerate it quite well. We give them a single dose of prophylaxis just because we're breaching the urothelium, and the risks are really minimal for them. The key, if you're going to do it, is to not put a lot in. So I said 500 to 1,000 microliters. So 1 mil max. And we'll put in, like, this is a regular syringe, so we're estimating 100 microliters per shot, just a little bit. If you put a lot in, then it's going to look like on the planning CTs, like a bomb went off. It'll be like white everywhere. So there's a Belgian urologist, Bertrand Tombal, who learned this from us. And then when I talked to him afterwards, he said, oh, it was a disaster. Like, everything was white. And I said, well, you're putting too much in. It was to the point where our radiation oncologist wanted to actually be the person pushing on the syringe. So now that we don't let them do that, but there's a very minimal learning curve. And just by telling you is probably enough for you to overcome the learning curve to not put a lot in. Why do we do it? We had a meeting at Hopkins, the Greenberg bladder cancer meeting a couple of years, just before COVID. I remember we were at the airport wondering if we should be here. And I talked about fiducial markers, and it became clear to me that we're almost the only one around doing it. There's very few centers doing it. It's slowly starting to take off. For example, Washington's using it. I think Fox Chase is going to start using it for their patients. And the reason we do it is to decrease interfraction motion. So between the bladder movement over the course of your 20 days of treatment, and also intrafraction motion, movement of the bladder during treatment during that day. Does it work? There's not a lot of data to say this is going to improve your dosing, for example. So it's more indirect data. So this is a very small study. 3 radiation oncologists looked at 5 patients, and they would map out their treatment plan pre and post Lopidol on the scan. And they looked at agreement in their treatment plans and the overlap. So I think the first thing is in the middle column, without Lopidol, you can see how much variation there is in a radiation treatment plan. So I think this would be the equivalent of the volume outcome study for surgery. So there's heterogeneity for sure, and what they're circling. So there potentially could be heterogeneity in the outcome based on that. So for example, patient 4, they only had 14% overlap in what they drew on the bladder. With the Lopidol, that improved. The p-value is 0.06, but remember, it's only 5 patients. So you can imagine if they had 1 or 2 more patients, it would probably be improvements. It's still not perfect, 28%, but it is much better than nothing. And it was found to be more accurate than just doing bony landmarks. So this is what it looks like. It's this white stuff on the CT scan. It stays there. So one of the criticisms you'll read in the literature, or someone may tell you, is that it'll fade. We've never had that issue. If anything, I said, it's if you put too much in, and then it's like the whole half pelvis will look white, and then it hasn't helped anyone. It's important to remember that you've given Lopidol, because in your follow-up scans at 3 months, the radiologist will say, oh, the bladder's calcified. And then at 6 months and at 12 months. And then you may say, well, why is the bladder calcified? This is a recurrence. It's just because you put the fiducial marker in and it's still there. Up to a year. Yeah. So we haven't had any fading. But all the studies on the fiducial markers here are 5 patients, 10 patients. They're so small. And so this is how they would treatment plan with their clinical target volume and planning volumes. Here is a complicated IMRT plan, 7 beam. And you can see the Lopidol on the patient's left-hand side, bottom left. So there's a fair amount there. Here are other options, gold seeds. The problem with gold seeds is they can become dislodged. And if they're not dislodged, then I would always worry about their lithogenic capacity and what happens when you leave them in there. Presumably, I guess if they're beneath the urothelium, it won't be a problem, but very few will use gold seeds. endo clip. This was recently published out of Brazil, and you can see in Exhibit A, about 2 centimeters, they have almost like a jaw with a clip on the end of it. So you have to be able to adhere this to the bladder mucosa. So there in Exhibit C, they have an edge from our TOR, and you can see that they can actually attach it there. But if you don't have such an edge, it may be hard to actually clip it on. And it has to be done with a rigid scope. So I would not be a fan of that. I think we had to use either cognitive fusion, if we want to use that term for bladder. So sometimes our radiation oncologists, when we were doing rigid scopes, if it was too much for the patient, they would just map it in their minds, and they would plan it based on that. Or something that's more tolerable to the patients. I guess in theory, we could give them sedation or general anesthesia, but it seems like overkill. Occasionally, at the time of a debulking TUR, we'll do it, and then we can do it with a Botox needle with a rigid scope. Okay, so at the bottom of that sheet that the coordinator puts together is this follow-up regimen, which should be easy for us to actually remember, and for everyone to know that after 6 months, that's highlighted, that's what they're there for. At 9 months, they just need a scope. And then if they're there at the 9-month mark, that would be highlighted. And at 12 months, they need a cysto and a CT. Should be straightforward. But remember, we have so many trainees and house staff and et cetera coming through. It just makes it a lot easier to say, where are we in the patient's trajectory? We don't actually have to look back and say, oh, was there trimodal therapy 3 months ago or 3 years ago? It's a shared clinic, so I may not see the same patient over and over. So this is actually very invaluable, even though it looks minor. It helps us in terms of efficiency. Here's a post-neoadjuvant chemotherapy patient. This patient would have had debulking. It's an odd-looking tumor, but we would never just treat this without debulking. We don't want visible disease. There is also skill in following up these patients and understanding what the radiated bladder looks like. So it doesn't look that bad. There is some scar there, but we can have larger scars and yellow sloughing tissue, and have come to realize that the radiated bladder takes a long time to heal. So we'll accept that for 12 months. Initially, if we have any suspicion, we would resect it, because we don't want to leave any muscle invasive or otherwise urothelial carcinoma. But for the most part, we would just get inflammation. So that's we recognized what looks like scar and healing tissue. And these are examples of what we can see later on. So the left-hand side is pretty marked telangiectasia. That patient would probably have a lot of symptoms. We don't see that often, but the right-hand side, you can imagine how you would think that this could be a tumor recurrence. So it just takes a while to understand what the post-trimodal therapy bladder looks like. If you were to use something like narrowband imaging here, it just makes it turn green. I don't think it's helpful. Dr. Zalata thinks it does, so I don't use it that much, and so I think it's whatever you're comfortable with. And we don't have blue light cysto, we have blue light TUR. So maybe blue light cysto would work there, but there's very few jurisdictions that would do that. And I just don't see that coming into Canada. For every cystoscopy patient, having them sit around and it's still an hour, that would be a nightmare. It's one thing if you're doing it for TURs, which is also painful. Okay, so we talked about cherry picking. We are cherry picking. That's the whole goal, right? We want to find the patients, the limited number of patients where we can give them the same outcome without a cystectomy. And that's only 25%, like I said. In Canada, we have so many patients. Our wait lists are huge. I assume it's the same here. It's not like we're clamoring for cases. So this helps offload some of that as well in a fashion that allows patients to have good treatment, uncompromised care. What about toxicity? So these are results from RTOG bladder sparing trials. Grade 3-4 toxicity, 6% GU and 2% GI. The Mass General group, Bill Shipley published this a long time ago, 91 salvage cystectomies, and all of them got ileal conduits. So we rarely will do a neobladder in this setting. Sia Dineshman has published on neobladders after radiation to the pelvis or trimodal therapy. I think it really just depends on the desmoplastic change and how close you are to the radiation. A radiated pelvis 8 years out is much different than a radiated pelvis 3 years out. So here are the updated Mass General data. So the table on the top left is their 90-day complication rate, early complications, and on the bottom left are their late complications. So they looked at 3 sets of patients. So they looked at patients who just had a primary cystectomy for urothelial carcinoma. That's the first column. The second are the salvage cystectomies for trimodal. And then the third are cystectomies in patients with prior radiotherapy for other malignancies, cervical cancer, colorectal. I think the first thing to point out is these were over 10 years and they only had about 250 cystectomies overall, including their primary. So they're not a high volume center. So I guess interpret that as you will. But in terms of the salvage cystectomy complications, much higher than the primary cystectomy. So I think patients have to be aware that they may if they need a cystectomy, and it's about 12%, that unlikely we're going to do a neobladder, and you'll probably have a higher risk of complications. It's usually GU type of complications like strictures, stomal stenosis, things like that, wound complications. Okay, now I have basically rapid fire about 6 or 7 areas of focus that we need to think about. Any questions on the practicalities of trimodal therapy? I think it's also important to have dedicated radiation oncologists. Can't be someone who's dabbling. So we have one for sure, Peter Chung has been with us all the way through. And then we've had other radiation oncologists come and go, but they're all devoted to the program. They never skip clinic. They're always there with us. So that, I think that's really important as well to get good outcomes. Okay. Some updates and controversies. How are we doing time-wise? Are we okay? 15? 10. Okay. All right. So I'll go this quickly. Yeah. Population-based studies. Most of the population-based studies will favor cystectomy. And the problem is there's a lot of selection bias in those studies. So here's one example from SEER. And you can see that there are improved overall survival with radical cystectomy over trimodal therapy. But I would expect that from those types of studies because they're American studies. They're not doing a lot of trimodal therapy in America, especially historically. So one would question, why did the patient receive radiotherapy? And it may be that they've selected the worst patients for that, and hence their survival would be the worst. Would be worse. And they miss granular data like CIS, hydro, the quality of the TURBT, dosing, the type of radiosensitizer. So I usually discount all of those population-based studies for this these indications. We looked at this in the top left is where I want to direct your attention. So we looked at single center studies and what outcomes they would usually get versus the population-based studies, just to demonstrate or at least provide some evidence that the population-based studies always skew to favoring cystectomy, whereas the individual centers where you can actually get the correct data and do the right analysis are usually right in the middle. They're not favoring any modality. So it was one of our ways to try to show that there are biases in some of those studies. Okay, neoadjuvant chemotherapy, we do that. Some centers do it, some don't. This one I think is variable out there. And the concept is we do it for radical cystectomy to help with micrometastatic disease. I think that would be the main reason to do it. And that's how you get your survival advantage. It also is a benefit for downstaging. So then our thought was like, maybe the paradigm should be neoadjuvant chemotherapy and then some form of radical therapy, whether it be cystectomy or radiotherapy. So we've been doing it for radiotherapy as well. And our medical oncologists have actually published this. And basically all we need to know is the top box. The way we give it is 4 cycles of GemCis. They are not MVAC or dose-dense MVAC fans in our center. So it'll take a while before they move over to that. And they image after 2 cycles. And if there's no progression, they continue on. If there's progression, then we just bring them right to cystectomy. And after 4 cycles, if they need a maximal TURBT or additional work, then we'll do that and they move on to trimodal. What's the evidence for neoadjuvant? So not one trial has demonstrated a clear It's a highly significant p-value. This is probably the best trial. It's the old MRC trial where patients received CMV neoadjuvantly, and then they received some form of radical therapy, just like I said, that paradigm. And so on the left-hand side, they did a subgroup analysis. So the left-hand side are the cystectomy patients, improvements in overall survival with the CMV neoadjuvantly, and the surgery group. We're aware of that. That's been meta-analyzed and published all over the place. So it's in all of our guidelines. On the right-hand side are the radiotherapy patients. The Kaplan-Meier curves look eerily similar. The hazard ratio is 0.8, maybe not 0.74, and the p-value is 0.07. So because of that p-value, I think it hasn't been accepted, but it's pretty close. And maybe we shouldn't be so dogmatic on our p-values, what I would say. So Wes Kassouf put all the Canadian data together. So all the centers that do tri-modal therapy sent data to him. And I haven't seen this. I've seen it in abstract form. So I just pulled it from their abstract. So he ended up getting a data set of 599 tri-modal therapy patients. We sent about 100, 120. They're the highest volume center, I think, in Canada. They had about 150. And they're prolific in publication. And then smatterings from here and there. And 17% of patients had neoadjuvant chemotherapy. And you can see the patients who had neoadjuvant chemotherapy had much better cancer-specific and overall survival. You could always argue that maybe this is selection. They did propensity score match, but it's additional evidence that neoadjuvant may be the way to go in these patients. And I think after this, Wes has now started doing neoadjuvant after they analyzed these data. Fiducial markers we talked about, so I won't go over that. Post-trimodal therapy biopsy, I've gone back and forth with Kassouf on this one as well. Toronto doesn't do it, McGill does do it. And this is the study from McGill that supports why they do it, or that they use as support. So they looked at 169 patients, that's the top box. Suspicious patients, so at the first cysto, suspicious cysto or positive cytology, all of us would do something there. So I don't think we have to think about those. It's really the ones on the right-hand side, 140 patients with a negative cytology and okay looking cysto. There's a lot of subjectivity to cystoscopy. Even in their group, 84 didn't get a biopsy, but they did biopsy 56 of these normal appearing, normal cytology scenarios. And 3 had muscle invasive disease and 6 had non-muscle invasive disease. So should we biopsy every single patient to catch these 3 out of 169? Or let's say 140 to be fair, or should we wait 3 months and let it declare itself because we've already treated, debulked? Will it make a difference? We don't know. So we haven't really changed what we do and they haven't changed what they do. So we're going to continue on, but it'll allow us to study it in the future. How do we manage intravesical recurrences? I'll just move forward. So the way we do treatment of non-muscle invasive recurrences is basically like they're de novo, because they are. Most of the patients will not have seen BCG. It's the only the odd patient that would have been the BCG failure that ends up, or unresponsive, that ends up with muscle invasive disease. Most of our clientele coming in, patients, are de novo T2, T3, T4s. So what we did is we looked at how many had a non-muscle invasive recurrence. So out of our 124, at the time we interrogated our database tri-modal therapy patients, 12 had a non-muscle invasive recurrence. Most of these are within the first 2 to 5 years. And then we matched them with de novo patients who appeared with just non-muscle invasive disease, matched to stage and grade and EORTC risk of recurrence, because we wanted to see, are our recurrence rates worse post-trimodal? Are we doing these patients a disservice? Should I just do a cystectomy since they've demonstrated they're recurring? And if anything, the de novo patients seem to recur more often than the trimodal therapy patients. The cystectomy-free survival is the same. So we're treating them just like they're de novo non-muscle invasive coming in. They do that also in Boston, and they looked at their data, 342 complete responders out of their trimodal therapy patients, 85, so 25% had a non-muscle invasive recurrence. Some individuals will say, or some centers will say T1, just take the bladder out. I don't think that's unreasonable. In their center, they had 17 T1s, 10 of them were treated conservatively. We have treated T1s conservatively as well, with success with a re-TUR and BCG. So I think a lot of it has to do with the size of the T1, the timing of the recurrence, if it's multifocal, things like that. Okay, final set of slides. Variant histology. Does trimodal therapy work here? We have very little data on this. This is one publication. It's one of the only ones in European Urology, and they looked at 66 variants. If you look at the top 3 of their variants, though, I wouldn't call those variants. I would call that divergent differentiation. There's not a lot of controversy about squamous glandular differentiation. They usually do the same as pure urothelial. What we're more interested in, I think, in the urothelial carcinoma community are the bottom ones. So sarcomatoid, micropapillary, neuroendocrine, nested. Can we actually treat these the same as a pure urothelial? But look at the numbers, like 15 patients. Nevertheless, when they put everyone together, they are not finding any differences in terms of overall survival, bladder cancer, disease survival. John Azawa did the same study in that trimodal therapy database that Wes Kassouf put together and found no difference as well. That's just in submission mode now, so that hasn't been published. So we do have some Canadian data. And the caveats are small numbers, like I said, we're in the teens. Lack of data on the degree of the variant. So is it 5% micropapillary or 95%? That would be a big difference, a very meaningful difference. The histology at TUR may not represent the final histology at cystectomy. So there is some discordant there. And it's all retrospective. So some of these pure urothelials may have actually been variant. We just didn't know back then. Quality of life. So just for time, I'll go through this very quickly. Again, not a lot, six studies, 4 retrospective, 2 prospective. None of them seem to show a difference. If anything, the quality of life seems to skew towards trimodal therapy in the long run. There is an abstract at GeoASCO that has demonstrated the same thing. It was a systematic review and meta-analysis. And remember, this paper I pulled it's from 2015. So it's got to be at least 8 to 10 years old. And the systematic review and meta-analysis said that there are 6 such studies. So I think nothing has happened in 8 years here. So they found the exact same results, and that will be presented in a day or 2. I'll just stop here. Current trials. Okay, maybe I won't stop yet. Almost done. BL13, just close to accrual. This is adjuvant durvalumab, and this is a Canadian trial. I don't know why close. I think it was just lack of accrual, actually. And we just got word of that from CCTG. I got the email last week. And the SWOG NRG trial you'll hear a lot about. It's called INTACT. S1806 is concurrent chemorads with or without atezolizumab. So there are a number of trials where we're trying to combine immunotherapy with trimodal therapy, either concurrently or adjuvantly or both. And this is a subset of those trials. Again, it's an older slide, just from 3 years ago. So they don't have Keynote 992, which is pembrolizumab. They don't have a trial called Radio, which is durvalumab. They're all basically Me Too type of trials with the company's IO, their proprietary IO. Okay, so conclusions. Bladder preservation with trimodal therapy is becoming an established treatment for localized MIBC. I put becoming in quotes because I think it's actually here. It's not really becoming. I think we just need to adapt to it. In selected patients, we can get outcomes equivalent to cystectomy. And those are the patients where we should be having that conversation. If someone comes in with a 10 centimeter tumor with bilateral hydro and nodes, I would never offer them that. If they go for chemo and have some phenomenal response, then maybe we can consider it. So we sometimes use that as a selection criteria. Lots of opportunities to learn as I went through. These are our current individuals in that clinic. So UroOncs, RadOncs, our administrator, Cynthia Cook, puts everything together for us. And we've had a number of residents and fellows come through. And it's great for our SUO fellows. And then finally, back in the day with the Halstedian approach of radical surgery, we would take everything out. It was very morbid. And I think over time for breast and colorectal, that's changed. We have combined modality, organ preservation, and in bladder cancer, I think we're getting there. And so maybe we should be rethinking our dogma for all of these cases. Any questions?